And that in there. Good evening, everybody, and welcome to the Prostate Forum of Orange County, California. Tonight's presentation is Understanding the Patient's Perspective after treatment with surgery or radiation. We will be discussing topics involving brachytherapy, quality of life issues, and focal therapy with radiation. We welcome back Dr. Mitchell Kamrava, Director of Brachytherapy Services and Residency Program Director, Associate Professor, Department of Radiation Oncology at Cedars-Sinai Medical Center in Los Angeles, close to Hollywood. West Hollywood is the way I think of it. Here's what we do at the forum. We do monthly presentations led by top experts in their fields. So it allows you to get to know your treatment professional. Information from where to start detection to mitigating post-surgical effects such as incontinence and ED. We have Zoom meetings of our active surveillance and newly diagnosed groups and active metastatic group to provide information, discussion, and hope. We don't provide medical advice in our groups. We share personal experiences. Our website is prostateforum.org, includes meeting information and calendars, resources, and an extensive presentation library. Our future presentations are on our website at prostateforum.org. And most Saturdays, Dr. Metzger has a newsletter for you most Saturday evenings. We work entirely with volunteers. There's no one paid on our staff. We very much appreciate your donations. You can donate online. Simply go to our website at prostateforum.org. You can find the link here at prostateforum.org. Support us or mail your check or money order. No cash, please, to Prostate Forum of Orange County, 1519 East Chapman, Box 380, Fullerton, California, 92831. Anything you can do to help is appreciated. Please mute yourself during the presentation. During Q&A, please remain on mute until you are personally asking a question. Please put your questions in chat, and at least for the beginning of our Q&A session after the doctor's presentation, I'll be taking those questions out of chat and asking them of the doctor. Now, without any further hesitation, I want to introduce from Cedars-Sinai Medical Center, Dr. Mitchell Kamrava.
Great. Thank you so much for having me. It's always a pleasure to speak to this group. Always look forward to the interactions after the talk and always great questions from this group. So in many ways, I really learn as much from you guys at the end as hopefully I am able to teach you guys during this time. My focus tonight is just going to be to spend some time trying to think about kind of quality of life after different prostate cancer treatments, and how do we look at these things and what are the differences between different treatments. These are my disclosures. The ABS is the American Brachytherapy Society. I sit on the board of directors. ADROP is a national organization for program directors for residencies. And Theragenics is a company that does provide brachytherapy seats and just some book royalties. So the main objectives tonight that I'd like to address are trying to review some of the long-term quality of life data in prostate cancer after the three kind of most common treatments that are performed, which would be surgery. You can kind of see an image of that in the bottom left. External radiation, you can see an image.
I hate to interrupt, but thank you.
You guys see now?
There we go. Thank you. Yes.
Okay.
Okay.
External radiation is delivered from like a linear accelerator. You see this image in the middle. And then we'll talk about brachytherapy, which is kind of either delivered with low dose rate permanent seeds or with virtual seeds using high dose rate brachytherapy. And really want to spend some time thinking about what are the differences in bladder, bowel, and sexual kind of domains after kind of each of these treatments. So I think probably familiar to this group, prostate cancer, it is the most commonly diagnosed cancer in men in the United States. These are statistics from the United States for this year, and we expect kind of there to be about 270,000 new prostate cancer cases diagnosed in the US. And this is a list of the top 10, and you can see that prostate is the most commonly diagnosed cancer kind of in men. So that's kind of maybe the bad news, right? The good news, though, is that, how do men with prostate cancer do? So on the far left, you can see that most men, whether they're white or kind of black, present with localized disease, about 70%. So that means the disease is just in the prostate, not anywhere else. And then kind of in that 10 to 15% range, the patients will present with positive lymph nodes, and then a smaller group with distant disease. And the good part about the fact that most men do present with localized disease is that you can see on the right here that your chances of being alive at 5 years after diagnosis is extremely high, with either localized or regional disease, almost 100%. And unfortunately, that's not true with patients who present with distant disease. But the majority of patients are going to be diagnosed with localized or regional disease and should do excellent. And so this is an interesting conundrum a little bit in that the treatments that we offer our patients, while they can provide a high rate of cure, our patients will also be alive to live with potential side effects that we may cause. And it's really important to think about, not just in the short term what we do, but what are we doing to our patients at 1 year, at 5 years, at 10 years after they complete their treatment? So why is treating prostate cancer challenging in the first place? Well, here's kind of like a sideways view where the patient's front is here, their back is here, and the prostate is kind of outlined in this dotted red here. But right in front and on top is the bladder, and right behind is the rectum. So this is a real estate problem, right? So regardless of whether you're using radiation or surgery or Hifu or whatever it is, the fact is that you've got very close normal structures nearby, and that's why you can get side effects to the bladder or the urethra. The urethra runs right through the prostate. The bladder here is right on top. You can have GI problems because the rectum is right here behind it. And there can be sexual dysfunction because the penile bulb sits kind of right here. And there are nerves that sit on the side of the prostate called the neurovascular bundles. And we know that after radiation that sometimes some of the ED is related to kind of fibrosis or narrowing of the blood vessels that can feed the penis. So this is a tough area to treat. So what's the best way to treat it? This is like $1 million question. Every patient comes in wanting to know, well, what's the best? And the answer is that there isn't really an answer to that. There are a lot of effective treatments. Again, the two most common, are radiation or surgery. And there's a growing area of like ablation and different types of ablation, which you can see here. But even within, let's say, radiation, there are a lot of different things to think about. What type of energy is coming out of the machine? Is it photon? Is it proton? Are you going to get an 8 to 9 week treatment or a 4 to 5 week, or just one that's done in 1 to 2 weeks? And then there's a question of brachytherapy and different ways of giving it. So how do you choose? How do you figure out what's best kind of when you have all these options in front of you? So sometimes we try to go to guidelines to try to give us some better understanding of like what's best to choose. This is a page from the NCCN. The NCCN is a National Comprehensive Cancer Network. It's made of experts throughout, the United States at major cancer centers who meet each year to review the best data that we have to try to come up with pathways. Most men will be diagnosed with low or what's called favorable intermediate risk disease. So this is the page for favorable intermediate risk group disease. And you can see that the options that they put out are kind of active surveillance. EBRT is external beam radiation or brachytherapy. or kind of surgery. RP stands for radical prostatectomy. And usually in these guidelines, if there is like a clear winner, they will put in parentheses like category 1, meaning like we definitely know that this is the best. But if you notice here, there is no category grouping because, you know, we do think that the outcomes are pretty much kind of similar between all of these different treatment options, but they do carry different side effects. And so that's kind of what I want to spend time talking about. Why do we really want to talk about this? It's because we really want to make sure that we can educate our patients to understand what is going to happen to them. Because unfortunately, about 1 out of 10 men with localized prostate cancer experience some type of treatment-related regret at 5 years. Okay. The strongest correlations with regret that are seen is a mismatch of expectations versus reality on treatment efficacy and adverse effects. Right? So we're going to try to take some time to figure out how can we hopefully kind of educate our patients the right way so that this doesn't happen. Right? So here's a framework for trying to understand how we put all the different competing things together. So on one end of this kind of circle, you can see that we want to think about cure, right? You know, did the cancer come back? You know, did it metastasize? Did you die from this disease? Did you die from something else? So that's kind of one part of this circle to think about. Then there's other parts of the circle to think about as well, which is like acute complications. You know, did you go through surgery or did you go through radiation and have a major complication like around the time that you got treated? Fortunately, these are pretty low for both modalities. So the other part is thinking about, well, what happens to me long-term after this gets done? And I think an important way of thinking about this is not asking the patient to interpret, not asking the physician to interpret what you tell them in the clinic, because we know that physicians really undercall what patients tell us, but instead to get it directly from the patient. And so that's called like a patient-reported outcome, meaning that we provide you with a tool to fill out that we don't interpret, but we basically, we don't change what you tell us, but we say, this is what the patient is telling me, and I need to figure out how to kind of help the patient. In terms of the domains that have been identified to really think about, we kind of look at urinary incontinence, urinary frequency obstruction or irritation, so 2 different urinary domains. We look at bowel irritation, sexual dysfunction, and then just overall vitality in terms of like energy level or depression. So how do we evaluate these things? The most standard tool that is used is called the EPIC. It originally was a 50-item questionnaire, but everyone, including patients and physicians, said it just takes too long to fill out 50 questions. And so it was shortened to the EPIC 26. And now it's been shortened even more to the EPIC CP, which is just 16 items. And that's kind of what we standardly use in our clinic. So again, it covers 5 different domains, 2 urinary, 1 bowel, 1 sexual, and then 1 kind of vitality and or hormonal symptom score. So let's look at some of these questions in terms of like what we're asking our patients to kind of fill out kind of serially as they come in and at the time that we first meet them. So there's urinary incontinence score, where we're asking questions about urinary control, urinary leakage, and how big of a problem it is. Usually these questions are asked like, how often did this happen in the last 4 weeks? We try to evaluate urinary irritation or obstructive symptoms. Do you have pain or burning? Do you have a weak stream? And do you have a need to urinate frequently, right? When we look at like the bowel scores, we're trying to ask questions about rectal pain or urgency, increased frequency, and again, overall, how much of a problem is this for you? Go to the sexual score. Again, we talk about, you know, what do you think your ability is to reach an orgasm, the quality of your erections. And again, it's important to think about how much of this is a problem for you. For some men, this is the most important thing. For other men, it's not. It's going to vary really for each patient, right? And then the vitality score, sometimes a little bit more relevant, some of the questions for patients that are on hormone therapy, the question about hot flashes or breast tenderness, and then questions about depression and lack of energy. So how do we put all of that together? And we're going to spend some time looking at some of this data. Is that what you can do is that you can track these scores and sum them together. And basically, this is what's called a radar plot. And how it works is that the best treatment that you could ever have, you would score 100 in every single one of these domains. And so this tracing would be all the way out on the outside of kind of this circle. But nothing is really perfect, and some things have pros and cons in different areas, right? So what this allows us to do is look at, like, where is it kind of lower, right? So for example, in this case, urinary incontinence is not at 100 over time, but is a little bit lower. And urinary bother is a little bit lower, but the bowel bother is better, and sexual function is worse. And so it allows a patient to try to kind of look at all of these things in one place to be like, well, what's most important to me? You know, is it sexual function? Is it that I want no disease recurrence at any cost and I would be willing to accept kind of more complications? And the answer for each patient is going to be different, right? But this gives us a framework to try to understand how to put it all together. So what I want to do is try to look at what data like do we have on patients that have been treated kind of with surgery or radiation where they did this EPIC tool kind of going out beyond 5 years. And why do I want to focus on more than 5 years? Because again, most people are going to present with localized or regional disease and they will be alive beyond 5 years. So it's important to think about that. And you can't lease your body. So you can't say like, I'm just going to suck it up and it's going to be fine and I'm going to do this treatment, because you can, but then there can be long-term kind of consequences to that. And it's just important for you to understand, like, did I understand what could happen to me, right? So this is kind of a busy slide, and we're really just going to focus on the top two studies. But these are studies that have been done where patients were treated with surgery, brachytherapy, or external radiation, or even active surveillance, where the patients kind of serially filled out the EPIC questionnaire. You can see there's not a huge number of these studies, and most of them kind of have follow-up in the 6-year range. A few have follow-up beyond 10 years, but those beyond 10 years were relatively small in number. And I think the two that are best and that we're going to spend time looking at are the PROTECT study and the CSER study. Okay. So let's look at the CSER registry. So this included men who were treated with standard of care. This is a group of men with just favorable intermediate risk prostate cancer. And patients either had nerve-sparing prostatectomy, they had external beam radiation, low dose rate brachytherapy, or active surveillance. And they basically asked them to fill out this EPIC questionnaire kind of over the course of kind of at least kind of 5 years. And they had about 77% compliance when they did that, which is pretty good. So let's look at kind of how things kind of change. So again, if you have a dot here on the 100 on the outside of this pentagon, that means you've got like perfect function. And if you have a dot closest to the middle at the 0, that means like the worst function. So again, ideally, every treatment would be on the outside of the pentagon, okay? So if we start here with A, so this is 6 months post-treatment, okay? So it's 6 months post-treatment. We look at the red here. This is nerve-sparing prostatectomy. The dark blue is the external radiation, and the light blue is the brachytherapy. and the orange are patients with active surveillance. So if we start with urinary incontinence, you can see that at 6 months, this is based on patients reporting things, that the surgery group does have a higher kind of urinary incontinence score at 6 months. And the brachytherapy, the LDR group, is a little bit kind of worse than the group that just got external beam or just got active surveillance. Okay. When we go down to the urinary irritative scores, you can see that the patients who got LDR brachytherapy, they had a little bit more irritative symptoms compared to the rest of the groups, right? The same is kind of true with bowel function. Again, the brachytherapy group's pretty close to the other groups, but is a little bit kind of less. All the groups kind of overlap on hormone function because this group of patients did not receive hormones. But then you can see all treatments do significantly impact sexual function. You can see the biggest impact at 6 months is in the surgery group, but there's still significant impact from external radiation or low dose rate brachytherapy compared to men who just got active surveillance. Okay. So here's a snapshot. This is 6 months. So what happened to these guys if you continue to follow them out, to 5 years? How do these things change? Okay, so let's start again with urinary incontinence. The surgery group does get better, right? They don't go back to like 100 in this group, but they definitely get better. And you can see the LDR group kind of overlaps now with the external beam and the active surveillance group. If we look at the urinary irritative symptoms, you can see that the surgery group's a little bit better, but these are pretty close to each other. Bowel function, things are kind of overlapping. Hormone function, things are overlapping. And then here's what's kind of interesting on the sexual function. So again, at 6 months, it looked like radiation was better, right? But if you wait long enough, these kind of curves really converge on top of each other, right? So, we see the sexual impact after surgery sooner, but the changes after radiation catch up to us as well over time. And you can see that for any treatment modality, really the greatest impact, I think, long-term tends to be an impact on sexual function. Okay. So let's look at the unfavorable intermediate risk cohort. So these are patients that would have just gotten external beam radiation therapy and would have gotten like a short course of hormone therapy. Okay. So again, we have on the left the 6-month data, on the right the 5-year data. The red line is just radical prostatectomy, and the blue line is the external beam with androgen deprivation therapy. Unfortunately, they didn't include a group here who got external beam plus brachytherapy. So again, we do see similar trends kind of in the short term with bigger urinary incontinence at 6 months with surgery compared to external radiation. Happening here, the bowel function maybe a little bit worse with the external radiation, but close. And again, the hormone function a little bit worse with the external beam, which is just related to the fact that they got hormone therapy. But look at the impact on sexual function. Again, a much bigger impact at 6 months with the hormone therapy with external radiation, and a bigger impact post-surgery, right? Again, if we look at these changes and how do they evolve over time, we do see some improvements in the incontinence with surgery, but again, it doesn't kind of return back necessarily to exactly where patients started. Things stay about stable for external, the irritative symptoms roughly overlapping, bowel symptoms, looks like when it was a little bit worse with external to begin with, that these resolve in the overlap. Hormone function is about the same as the testosterone recovers. But again, this similar kind of really long-term problems with sexual function for both treatments. So there's no winner here, right? I mean, this is a problem for all of us that treat prostate cancer. So let's just look at a different study. Do we see similar trends if we look at a different study? This is the PROTECT study that was done in the UK. This is a much larger group of patients, including over 1,000 patients who got active monitoring. We call it active surveillance, similar thing. 750 radical prostatectomy, about 600 who got external radiation plus androgen deprivation therapy, and a small group that got low dose rate brachytherapy. Okay, so kind of what do we see here, kind of in the short term and long term? So if this is the EPIC questionnaire, again, that we were talking about. This is the most standardized kind of way of measuring patient-reported outcomes. Again, what we see is kind of 1 year into treatment. You can see this red line. This is radical prostatectomy. And you can see the brachytherapy line, that the urinary symptoms are a little bit higher, certainly in that first 1 year, kind of comes down over the next few years, and is a bit lower than patients who just got either active monitoring or external radiation. If we try to look at like, well, what are those urinary symptoms? What is it that's bothering these men? We look at this top right. So EPIC, asks the question about, are you using more than one or more pads per day? And what we see is probably the biggest difference is that some of the surgery patients can have higher rates of leaking as reported by the patients. And that's kind of greatest in the first year and then does like improve over time. But the active surveillance group and the 2 radiation groups tend to have less issues with leaking, a little bit more with brachytherapy compared to external radiation, but definitely both the radiation arms are less than the surgery arms. The flip is if we look at the irritative or obstructive scores, we see kind of a different story where the surgery arm is less. You can see in the red here. And the brachytherapy arm is a little bit higher in that first year. It does come down and kind of meet the active monitoring group and gets close to the external group. But there we do usually see more irritative obstructive symptoms with brachytherapy compared to external radiation. What about bowel function? How do we fare there? So here, I would say that in general, surgery is better, right? And that's because the surgeon doesn't really manipulate the rectum, but with radiation, there can be radiation dose that gets to the rectum and can irritate it. So none of these patients received anything like SpaceOAR, which can kind of displace the rectum. These were all patients treated without that. And what do we see like in the top kind of left? Again, we kind of see the lowest changes in red here, which is the surgery arm, with kind of slightly higher changes kind of in that first 1 to 2 years, and then improvements over years kind of 3 to 6 for the radiation arms. In terms of things that we see with radiation, we look at the bottom left here. You can see in that first year, there can be patients that have kind of looser stools. So I should have discussed, so on the y-axis, basically, we're looking at kind of the mean reporting kind of more than half the time, right? So these higher scores are kind of a bigger problem. So you want to be lower here. So we do see, these flare-ups of symptoms that do kind of resolve kind of over time, but you can see these flare-ups of loose stools are higher for the external radiation, lower for the brachytherapy, but certainly kind of the lowest line really in the red here with kind of the surgery, okay? Similar types of trends seen with the bowel bother score here and the fecal incontinence score. What about sexual function? We look at sexual function and kind of what's happening here years kind of after treatment. So we see that on this y-axis, this is our men reporting a lack of firmness. So kind of we can see over the years in surgery, you see this bigger drop initially, right? And then it kind of stabilizes over time, but it's a pretty significant number of men here that are reporting a lack of firmness. Now, that's not to say that this doesn't happen with radiation. Let's look at the blue line here, this lighter blue. This would be external radiation. So again, you see some increase within the first year, not as big as surgery, but then there is kind of this upward slope over time where these curves start getting closer to each other with more time. What do we see with brachytherapy? We see kind of a little bit more of a delay, right, to kind of issues with firmness with erection. There's a little bit of noise here. And, you know, it settles out a little bit lower and kind of closer to what is happening with age in this active monitoring group in this dark green. I do think that there's some controversy over whether or not the long-term ED risks after brachytherapy are really significantly lower than other modalities. But again, all of these modalities are having kind of long-term impacts, say, on erection firmness. How about in terms of men reporting problems, you know, how big a problem are they having with erectile dysfunction? And again, it's a similar story. Kind of these big waves early on, some improvement in the surgery group, whereas kind of the external radiation group, kind of the slope slightly goes up more over time. And again, this wave with brachytherapy happens a little bit later. And the rates are a little bit lower long-term, but I think with more follow-up, I think more of these curves are really just going to converge, but we'll have to see with more follow-up. Oops. So how about age? How does age impact things? They did try to stratify their data by whether men were under 65 or over 65. And you can see, like, let's say in the red here, this is the surgery arm again. You can see some differences in age. They weren't really that significantly different. You know, the younger guys do a little bit better, but it's still a problem, right? And it's still a problem whether you're getting surgery or radiation or just on kind of active monitoring. So better to be younger, right? I wish we could all stay young forever, but it seems like, you know, this is still a problem for both groups. So how can you like maybe use this information if you're a patient and want to be like, well, what might be my predicted, you know, outcomes in terms of impact on my bowel function or urine function or sexual function? You can go online and kind of use this resource. This allows you to go in and basically put in kind of your features of your prostate cancer. It's usually asking for your age, your PSA, and your Gleason score. And then it basically has you fill out an EPIC questionnaire. And then what it allows you to do is, this is using that data that I presented from the Caesar registry. It basically gives you kind of like, this is kind of what we would expect if you got external radiation in that green, or if you had radical prostatectomy, that's RP, or active surveillance, in terms of kind of how you would score kind of on the EPIC questionnaire. So I put two examples in here. So this would, let's say, be a 65-year-old gentleman, Gleason scored 3+4, PSA 5, so a favorable intermediate. And I filled it out basically that he's perfect. Like, he's got no bowel issues, no urinary issues, sexual function is rock star. And kind of here's kind of like what the curves would look like. So one thing we didn't talk about yet, but I'll talk about here is, one question is like, well, what's really the difference if someone scored an 80 or someone scored, let's say, like a 75? Like, does that mean something to me? And so people have done a lot of research to try to figure out what's like the minimum significant difference. And so, meaning like, what difference between numbers should we start to say like, yeah, that's actually like an important difference, and that's not just noise. So these are kind of like what people have suggested that if there's, let's say, a difference of between 10 to 12 in sexual score, for example, that's like a meaningful difference, or a bowel score of 4 to 6. So you can see the separations in these curves. Let's just look at, let's say, the sexual domain curve. So again, we see kind of these similar trends to what we've been talking about, is that a worse score is kind of down here at the bottom, a better score at the top. You can see as we get older with active surveillance, we do have a natural decline here, right? That's if we did nothing to you and just let age kind of work. We do see bigger declines here if you get external radiation, and there's also declines with radical prostatectomy. Again, if we look at, we can look again at these differences in urinary incontinence rates in the bottom left. We can look at changes with bowel function in the top right. Again, we've talked about how some of the bowel function changes can be a little bit worse with radiation compared to like surgery. And then where the flip is, there can be more incontinence issues with surgery compared to radiation. And the irritative symptoms, and usually these lines are pretty close to each other here. So what happens like if you don't come in with good function, right? So I took the same guy, but I put in like the worst scores. So this is a guy that like, he's got a lot of issues peeing already. He can't get an erection like pretty much at all. He also has issues with diarrhea. And you can see that these curves do shift down quite a bit. So how you come in to begin with really does impact how you're going to do after. And that's regardless of whether it's surgery kind of or radiation. You can see like in this bottom right, for example, really big fluctuations in urinary irritation scores kind of if you're already coming in with problems. And so it is important to consider, you know, how am I coming in at baseline? And these treatments don't all affect patients the same way, but really do vary by how they come in. The other thing as I try to kind of wrap up and then give people a chance to ask questions is how do you interpret really some of these scores? And we've been talking about them as scores relative to each other, like, okay, this person scored an 80 and then it changed to 75. And this would be a clinically significant difference. But what does that like really mean? And there are kind of studies that help us try to understand what this means. And that, for example, in terms of sexual function, someone scoring between 80 to 100, you know, the vast majority of those men have erections that are sufficient for intercourse. But if they're scoring in the 40 to 60 range, it's closer to about a third, right? And similarly, you can have similar kind of translations, if you will, of these scores for like urinary incontinence for the other domains. I don't want to spend a huge amount of time kind of going into like comparing different radiation regimens, but only to say like, I've tried to spend most of my time trying to have a bigger picture talking about kind of surgery versus radiation, you know, versus active surveillance. But these types of tools of using EPIC can also be really helpful for comparing different types of the same treatment. So this is a study from the group in Canada who used the EPIC questionnaire to compare, like, how did our patients do who got Sbrt versus brachytherapy only versus brachytherapy plus external radiation therapy. And so these types of tools can also be like, these studies can be super helpful in discussing things with patients in terms of what do you expect to happen in the bowel function? What do you expect to happen in the sexual function? And really tracking them over time. This study is great because it compared all those things, but the downside is so far the comparison only goes out to 1 year. And again, as I was showing you before, we know that these things continue to evolve over 5 years and beyond. So future kind of directions, I mean, I think similar to that last slide is I think using the EPIC and taking the patient's perspective to understand what has happened to them through their eyes is really important as we try to compare all these different things to each other. I think, unfortunately, whoever you see as a physician tends to be pretty biased to what they do. But it is really important to try to consider the patient's perspective and how they kind of convey what has really happened to them. So hopefully we can continue to see comparative kind of studies that are using patient-reported outcomes over long term. The other thing is, if you look at the bottom right graph, this is taken from the Caesar registry. Each of those color this is what's called a box whisker plot. And this is looking at sexual function changes over time. Each of the colors represents a different treatment modality. But the height of these boxes, you can see, is very wide. And what that means is that different patients scored in a very wide range. And so the numbers that I was showing you are like what half of the men scored. So half of the men scored higher, half of the men scored lower. That means there's a group of men that are doing way better, but there's also a group of men that are doing way worse. And we don't really have great ways of telling you like which group you are going to fall into. And so trying to really personalize the information that we can share is definitely an area that we need to continue working on. The other thing that is kind of happening both in radiation, but also outside of radiation, we see that we cause these urinary changes, bowel changes, sexual function changes. And kind of $1 million question is, the standard treatment is either to remove the whole prostate or it's to radiate the whole prostate. And there's really a very, very kind of rapidly growing kind of literature on like, well, would men do better if we only treated part of the prostate and left the rest of it alone? Something called focal therapy. Really won't go into like truly the whole pros and cons, but this is kind of a holy grail that I think is an unanswered question in terms of like how much do we or do we not improve long-term quality of life if we treat less than the whole gland. But this is a pretty active area of investigation. And then the other thing is, are the EPIC questions that we went through really the best, and do they apply to everyone? We see patients who have all sorts of different backgrounds, all sorts of different needs. The sexual function ones, for example, those were really developed for heterosexual men having vaginal penetration, and they don't really always apply to patients who have kind of anal sex, where the penetration issues are different. And so they are lacking in some ways in certain regards, and there will be certain questions that are not part of the EPIC that may be more important to you, right? That maybe we have missed. So we do basically have a one-size-fits-all questionnaire for everyone, and that probably really is not right, and we probably are missing asking important things of different groups of men. So kind of my conclusion, I just put kind of a summary of the radar plot from the Caesar trial here, because I think it provides like a very reasonable overview of some different changes that you can expect between surgery or external radiation or low dose rate brachytherapy and active surveillance. I think what I hope that you take away from this is that hopefully I've provided a framework to try to understand what might be the long-term changes for each treatment. Each one has different changes, right, that can happen. I encourage you, if you're newly diagnosed, to take your time in deciding. You don't need to rush into treatment. Make sure you understand the pros and cons and that you talk to different people, both patients and different physicians. You'll get different perspectives from both. And honestly, in terms of what is the right treatment, it's going to be, it's going to depend on each patient and what matters most to you. Is it going to be urinary issues that matter the most to you? Is it going to be cure? Is it going to be sexual function? Is it bowel function, or some combination? And the answer to that is going to be different for everyone. So with that, I'll go ahead and stop and see if I can answer any questions.
Thank you, Doctor, for an excellent presentation.
Neil?
Let's start with Ira. Ira has a question. In the Caesar study that you presented, are the patients age comparable, or are the surgery patients younger? If the younger surgery, if younger, was surgery surgery might have been at a greater disadvantage. In other words, if I read Ira's question correctly, would those younger patients have been better off, let's say, with focal therapy or whole gland radiation?
No, my question is, in the study, if the surgery patients are younger, they would have a greater sexual function than an older patient. So are the patients comparable in age, or are the subjects younger? The surgical subjects younger.
So in general, in most surgical series, the patients do tend to be younger, but there weren't major differences in age. It was something that was controlled for. But yeah, in general, most surgical series do tend to have younger patients. Most radiation series do tend to have slightly older patients. So that is like a consideration, and it is a little bit of a confounder. But I think whether they're younger or older, you can still see the overall general trends. And I think that's going to hold true whether they're kind of younger or older. Good question.
Okay. Joe wants to know, are the side effects comparable for LDR and HDR?
Yeah, so that is a great question. So we will have, for the first time, presented at our annual American Brachytherapy Conference, a randomized trial of HDR versus LDR as a boost, which is getting presented. I'm going to be the discussant of that. So I can't share the data yet because it's embargoed for about 2 weeks. But the data that we do have, I would say, when you use LDR only or you use HDR only, so not in combination, is that in general what we see is that the short-term irritative urinary side effects tend to be a little bit more intense with the LDR and tend to take a little bit longer to resolve. But once you get out to like 6 months or 12 months, the side effect profile is similar between the two. And we don't really have data that long-term like PSA control rates are significantly different. There's some controversy over whether or not sexual dysfunction issues are different long-term, but the biggest thing that we see would be short-term urinary side effects tend to be a little bit more intense with LDR and take a little bit longer to get better. Sorry, someone wrote in, what are these abbreviations? So LDR is low dose rate brachytherapy. So these are permanent little radioactive seeds about the size of a grain of rice that are permanently implanted into the prostate. HDR is high dose rate brachytherapy. And so there are usually little straws that are inserted through the skin between the scrotum and the anus called the perineum directly in and around the prostate that allow a temporary radiation source to go inside of those straws, deliver the radiation, and then the radiation source comes out. So you're not left with permanent seeds in the prostate. And Sbrt is stereotactic body radiation therapy. It's a type of external radiation that delivers all of the radiation treatment in just 5 treatments, whereas traditionally it's been given over either 5.5 weeks or even 9 weeks. So it's a much more compacted, condensed course of treatment over just a 1.5 weeks, and it's most typically given every other day.
Okay.
Neil?
Yes.
Yes, could I make a comment?
Yes, please.
Hi, Dr. Kamrava. This is Dr. Metzger. That was just a wonderful, wonderful talk. It kind of clarified for a lot of us some of the differences. I think also men that are on active surveillance, which a lot of our men are, if you notice the one graph, there is a decline in function.
Yes.
And so active surveillance does have a diminution of function of some sort over time, but that's called aging, and that's just the way it is. So, I mean, even active surveillance, you could say, has its issues, but it's just very well illustrated the different types of treatment and what people can expect. Would you say there's more HDR being done than permanent seeds, or the other way around?
I think that as a boost modality, so for patients with, unfavorable intermediate risk or high risk disease, I think there's a greater trend towards using HDR. It provides a little bit more flexibility if you need to cover outside the capsule of the prostate or the seminal vesicles. When it's used alone for like a low risk patient who chooses to get treated and not be on active surveillance, or favorable intermediate risk, it can be used alone without external radiation. I'd say in that space, I think LDR is still a little bit more popular, for the main reason being that LDR is a one-time procedure. You kind of go in, these seeds are placed in the operating room, and you wake up basically with the seeds in the prostate. But with the HDR, it needs to be done as 2 treatments. And so that means 2 trips to the OR that are usually spaced 1 or 2 weeks apart from each other. People have tried doing HDR in 1 treatment, and unfortunately, it is not as effective. And so it is not standard to do just 1 treatment of HDR. So for men that aren't bothered by the logistics of the 2 treatments, I think, the HDR works out. But for those that want like a one and done, the LDR is still kind of the only thing from a brachy standpoint that can be one and done.
Yeah. Thank you again. That was a great talk.
Yeah.
Francis wants to know, are there Caesar and Protect T studies looking at whole gland treatment, focal treatment, or some mix? I assume they are looking at whole gland since their patients were 10 to 15 years ago at the time of the treatment. It seems that focal is much more common today.
So that's correct. So everyone in the studies that I presented was whole gland. I'd say, focal therapy is still not standard of care. When you look at the NCCN guidelines, it's still considered whole gland as the standard. But I agree, there's a lot more focal therapy that's being done, whether it be laser or Hifu or cryo, etc. There are starting to be more comparative studies looking at quality of life changes using EPIC after focal therapy. There are still sexual function changes, even if you just treat half of the gland or part of the gland. And so I think focal therapy, as exciting as it is, it's also super complex, super complex thinking about, did we control the disease? Did we control the disease, but there's new disease somewhere else that wasn't treated? And how do you then match, the treatment? So there's a lot to think about. We don't have like as robust of a follow-up or randomized data of whole versus half using like EPIC and having data that goes out 5 years. I would love to see that data. I think we will see it eventually, but I'm not aware that we have it yet.
Ira wants to know, how do the cure rates for LDR, also the side effects and cure rates for LDR, HDR, and Sbrt compare?
Yeah, so this is also a pretty active area of discussion. It's difficult to generalize that. I would say if we're talking about a favorable intermediate risk patient, I think we expect the PSA control rates to be in the 90% range for all of those modalities. Most of the Sbrt data goes out to a median follow-up of about 6 to 7 years, although there are series that go out to 10 years. The data duration is similar for HDR in terms of median follow-up in the 6 to 7 years, with some with longer follow-up. So far, the curves in terms of PSA control look very similar. We do have longer data with LDR going out to 15 years, again, suggesting that those PSA control rates hold steady going out to a long term. I think the most important thing to realize is that prostate cancer is a slow growing disease, right? And so a lot of things look great at 5 years. You really want to see what things look like at 10 years or beyond. We see almost a quarter of recurrences that can happen after 10 years, right? So people that are really excited when they show you data with just 3 years of median follow-up, have them call you again in 5 years, right? This is a slow growing disease. It takes a long time to see things. If you're already seeing that things aren't working after 3 years, that's a big red flag. It's not going to turn out well. And so that's kind of like a general comment. Hopefully that answers the question.
Okay. How does focal brachytherapy compare to focal Hifu laser as far as not just side effects, but if the disease comes back, retreatment?
Yeah, so I think my comment on that is I think that brachytherapy has a very long track record of being very successful and working, right? So we know that radiation, whether it's brachytherapy or external beam, has a very high chance, let's say in a favorable intermediate risk patient, of controlling the PSA. So radiation does not have the onus of proving that it works. What it does have the onus of proving in a focal therapy setting is that if you treat less of the gland, will this man have less urinary, bowel, and sexual side effects compared to if you treated the whole gland? And that's still not a totally answered question, right? I think for the other modalities, the long-term control with Hifu is not as high as what we see if you do surgery or if you do radiation. So, and that's true with laser or other modalities as well. So I think the burden on other ablative modalities is actually twofold. Is one, proving that oncologically it has the same long-term control as surgery or radiation. And then the second is, what does it do functionally? I know for sure that there are some men that would accept like maybe a lower chance of PSA control, and maybe they could go back and do a second Hifu, but if they knew that it would preserve sexual function and less urinary side effects, they would take that risk. And again, so this comes down to like an individualization of like, what is most important to you? If it is, let's say, sexual function, then maybe it is worth, trying to do Hifu and just treating part of the gland, accepting that maybe it doesn't have the same efficacy as surgery or radiation, but it may have less of an impact on your sexual function, right? So that's a very personal decision that I think is really varies for each guy.
Rick wants to know Proton versus Photon. Which one has less side effects?
Yeah, so we will have like a final word on that very soon. A randomized trial of photons versus protons. Multi-institution study has been completed and it should report out soon. From the data that we do have, there's really no good data that protons has a more favorable side effect profile compared to photons. So even though in theory it's supposed to have less, it does not appear in the data that we have that there are like less rectal side effects. And part of that is, I think, the technologies that we have to deliver radiation now are way better than kind of what we had 10 or 15 years ago. And the overall rate of serious rectal complications is way lower now than 10 or 15 years ago, including, rates of radiation proctitis or long-term issues with like diarrhea. They're way better now. And, a lot of people for appropriate candidates are also kind of using things like SpaceOAR, which can displace the rectum further away from the prostate and limit the amount of radiation dose even more. So I don't personally feel that there's like compelling data that that proton treatment is really better than photon treatment.
Okay. I got what looks like an active surveillance question from Ed. What's the worst thing that can happen long term if I'm 60 years old, Gleason 3+4, Pyrat of 4, 2 of 12 cores with 70 to 90% involvement, and very healthy other than this diagnosis?
Yeah, I don't want to provide medical advice without really, reviewing everything. I mean, I think the challenges with active surveillance are similar to like what we were talking about with surgery or radiation. There are some real pros to it and there are some cons. It's not the right thing for every patient. So I think in terms of what things can go wrong. So, one question is like, do you think about this every day, right? Does it sit on your mind? If it's something that's occupying your mind every day, that's problematic because you really should be trying to enjoy life and, living your life. The issue with active surveillance, which is true for every man, is not unique to this case, is did we find the most aggressive portion of prostate cancer that's in your prostate, right? The whole reason it's not called watchful waiting and we just say like, go away, we don't need to see you, is that we're all trying to make sure that we didn't miss something that, would make us say that you should get treated. And, we're getting better and better with MRI and targeted biopsies and using things like Decipher or Polaris. But this is what everyone is trying to do, is just make sure we didn't miss something more aggressive that should then make us want to recommend doing treatment. So that's always the risk. I think, do you try to only recommend active surveillance for patients where we feel that risk is low? Otherwise, we would recommend doing something. So it's kind of a complicated question. And I don't want to provide, real medical advice without reviewing everything, but hopefully that just gives a general sense of some things to think about.
Charles wants to know, does Brachy leave metal artifacts which can negatively impact MRIs?
So there are little voids that are seen with permanent seeds. You can still get an MRI and you can still see lesions within the prostate. So it doesn't prevent them from doing additional MRIs and being able to see what they need. But it does add a little bit of complexity because they just look like on certain sequences like little black flow voids. But the radiologists who have experience can kind of, if you will, work around that and still kind of give you good reads post brachytherapy with seeds. With the HDR, there's no permanent seeds that are left in. Sometimes people will place little gold fiducial marker seeds that there's usually just three of them that are put in, and they're pretty small, size of a grain of rice, so usually doesn't affect things.
Well, I'm going to go right to Ira's question, and I'm going to come back to some of the others. So how often do these permanent seeds travel?
Pretty rare that they would migrate outside of the prostate. Part of the evolution of how the technique is done is that many people will use what are called stranded seeds. So the seeds are kind of attached to each other like links. And so they're not loose seeds. And so the chances that they would spread or go somewhere else is very, very unlikely these days. Not a common occurrence. A theoretical one and can, but it's not very common that would happen.
Here's an interesting question from Francis. What role, if any, does the current research on, I hope I don't pronounce this right, methylization rates have on us clinically? Should we pay any attention to all of that epigenetic research? I hope I pronounced all that correctly.
Yeah, the epigenetic stuff. I would say I'm not aware that any of that information has reached a point where we know how to translate it into the clinic. So I'm not aware. I haven't been using that information really to influence treatment decisions in my clinic. If someone is aware of something newer that I should read, I'm happy to review that, but it's not something that I'm aware of that's really made it into like regular use at this time.
Okay. Does anyone else have a question? Doctor, do you have a question, Dr. Metzger? You're on mute.
No, it's a great talk. It answers a lot of the questions that we get frequently on the sessions we have. I really appreciate your taking the time.
Of course, always a pleasure to be here, and thanks for the great questions.
Thank you.
Thank you.
Ira wants to know how many brachytherapies have you done?
Probably over 1,000. I've been doing them since 2010. Before I moved over to Cedars about 6 years ago, I was at UCLA and kind of ran the Brachy program there during my last year, and then was recruited over here to Cedars to establish a Brachy program. And so I've been doing it a good amount of time. So always continue learning each case, but have been doing it for over 10 years now.
I want to thank everybody for being here tonight just before a major holiday and during graduations. It was a busy time. Attendance is good, and I'm looking here at names, and we have people from all over the United States on this call tonight. Is there any other questions that we can answer for you tonight? Getting lots of thank you for a good presentation on our chat. Next month, join us for a discussion of CyberKnife Sbrt with, let me get that on the screen share just a bit, Dr. Donald D. Fuller. And he will be here the fourth Thursday, which is Thursday, June 23rd, 7 to 8:30 p.m. for CyberKnife stereotactic body radiation. He'll be answering a lot of questions, and this notice will be going out June 1st. If there's no other questions, then I want to thank the doctor for his time, and I also want to encourage you to donate, even if it's just $5, $10. Your donations help us pay for Zoom and help us pay for our website. We are entirely volunteer. So all the money that goes out goes back into communication and things we need to provide services. You can find donation links at our website, prostateforum.org, and you'll see a link there to donate, either by check or by PayPal. If there are no other questions, and Doctor, if you don't have anything else for us tonight, I'll thank you all for coming and close the meeting.
Thank you very
As
Thank you all for coming, and have a great night.